Okay, thank you. Yes. So from hemodynamic interpretation of Doppler signals to clinical diagnosis, and I would like to start with two clinical cases. This is the Colour-Doppler evaluation of the right and left common femoral arteries in a patient who had pain on the leg artery of the left leg after walking 200 meters. And you will see that there is both the two arteries look normal. Flow on the right side is normal. Flow on the left shows delayed and small systolic peak. These indicate that there is a stenosis upstream at the level of the left iliac artery. And this was confirmed by CT. Another case, renal ultrasound in a 32-year-old hypertensive lady. On the left side, there is the Doppler examination of the left renal artery, on the right renal artery, and there is markedly increased flow velocity at the middle third of the right renal artery. And this indicates that there was a stenosis. The patient was directly addressed to angiography without need of any other imaging test to confirm the diagnosis. Fibrodysplasia was confirmed before dilatation. So, how can we make these diagnoses and be sure about them? Which are the physical principles of Doppler ultrasound techniques, and which are the hemodynamic phenomena we can evaluate with Doppler ultrasound? If we remember the ultrasound images, each echo is generated at the interface of means of different acoustic appearance, and the equipment measures intensity and position of the echoes, with depth determined by time delay between the genesis of the impulse and the return of the echo to the transducer. On the contrary, the Doppler effect does not measure position and intensity of the echoes. It evaluates the difference in frequency between the incident beam and its reflection. This difference is called delta F. This is the image of Johann Christian Doppler, who was an Austrian physicist who first described this phenomenon. As a matter of fact, an ultrasound wave refracted by a moving structure has frequency which is different from the one of the beam that hits that structure, because the velocity of the moving structure is added or subtracted according to the direction to the incident frequency. The typical example is the blowing horn of the ambulance. When coming, that same horn sounds with a higher pitch than when going away. And this is the equation which rules this phenomenon. Delta F is the Doppler shift, V is the movement, the velocity of movement of the target, Fi is the incident frequency of delta is the angle of incidence between the ultrasound beam and the direction of the movement, and C is the velocity of propagation of ultrasound in tissues. So delta F is equal to twice the velocity per the incident frequency per the cosine of the alpha angle divided by a constant C. In diagnostic ultrasound, the Doppler effect allows to evaluate the movement of the red blood cells within the vessels. They are so small they cannot be seen as visible echoes, but on the contrary, the frequency shift they produce can be measured. And we have two different methods, the Echo-Doppler and the Colour-Doppler. In the Echo-Doppler, during the examination, the examiner identifies a vessel at ultrasound, in this case the portal vein. Then the examiner positions the sample volume within the vessel, and the sample volume is the region of the images where the equipment will evaluate not the intensity of the echoes, but the frequency shift. Then push the button Doppler and listen to the sound that corresponds to the differentiating frequency, that is the delta F. And why do we hear sound? Because we are dealing with ultrasound, which is not audible. However, the incident beam is an ultrasound frequency. The reflected beam too has an ultrasound frequency, and then there are differences within the kilohertz range that is audible. The first examinations did not allow to make any recording, and you had to analyze the signals by ear. But nowadays, we can have the spectral analysis. And the spectral analysis is representation of 4 different parameters. The direction of flow, the delta F, that is the difference, the frequency shift, the signal intensity, and changes over time of these parameters. The direction is, by convention, flow coming towards the transducer is written above the baseline. Flow going away from the transducer is written below the baseline. Within this sample volume, there is both the renal artery and the renal vein at the renal hilum. So the artery is coming towards the transducer, written above. The vein is going from the transducer, written below the baseline. Then frequency shift. The higher the difference, the farther for the baseline the signal is written. Higher, I don't have any pointer, but anyhow. In systole, the velocity is higher. It is written farther than the baseline than in diastole. And the lower the difference, the closer to the baseline the signals are written. Intensity of the signal corresponds to the number of red blood cells running at each velocity within the sample volume. And it is represented by the tones of gray. The lighter the number of red blood cells, the lighter the tone of gray, and vice versa. And temporal changes over time along the baseline, changing of these parameters. What is color? It is a representation of 3 of these 4 parameters: direction, delta F, and temporal changes. So, okay. Flow direction. Flow running towards the transducers is displayed in red. Flow directed from the transducers is displayed in blue. And again, the higher the difference, the lighter the hue of the color. And the lower the difference, the darker the hue of the color. We know that the flow within a vessel has a parabolic shape with the higher velocity in the middle and lower velocity close to the wall. And you see the darker hues are written close to the wall of red. The lighter hues of red are close to the wall, the darker, and the lighter are in the middle. And then temporal changes, the systole and diastole representation of the renal artery at the renal hilum. You see that the color hues are lighter in the systole because there is higher velocity and darker in diastole. So these are the physical basics of representation of what we show. We see on Colour-Doppler and pulsed Echo-Doppler. But how to evaluate? We evaluate in a qualitative way, in a quantitative way, and a semi-quantitative way. And qualitatively, we can say there is flow, which is its direction, and which are its basic characters. Is it continuous or pulsed? And this is my first paper in Doppler ultrasound, which I wrote in 1984, that means I'm very old now, in which we were able to identify flow within some cystic lesions at the hilum of the spleen, and we could identify that these were aneurysms of the splenic artery. So presence or absence of flow within an image resembling a cyst is one of the first fields of application of Echo-Doppler equipment. As a matter of fact, color nowadays is the simplest way to differentiate with certainty between vascular structures which will show internal flow and non-vascular ones without internal flow, which are the vessels, the blood vessels and the biliary vessels in this patient with jaundice. The biliary vessels are those which are not flow inside. This is another case, middle-aged male, ultrasound performed for dyspepsia, unknown specific symptom, and a mass at the liver hilum was found. Then light up the Colour-Doppler, light up the pulsed Doppler, and you will see Colour-Doppler shows flow within the mass, and spectral analysis identified it as arterial flow. This, the patient had an aneurysm of the hepatic artery, which was confirmed then by CT. Direction. Please remember what we said about the color flow coding. These are two patients with patent portal vein, which is abnormal. Which is abnormal? The right or the left one? Left one, perfect. Because there is abnormal flow, retrograde flow. Now, I don't know if it moves. Yes, it does. So, first, look at the characteristics of flow within the vessels of real time, and then go to the spectral analysis. You will see that there is continuous or oscillating flow within the portal vein. There is pulsatile flow, arterial pulsations within the hepatic artery, and there is phasic flow within the hepatic veins. An evaluation of presence and characters of flow may allow specific diagnosis. This is a female, middle-aged, with a slightly hypoechoic mass in the liver, which Colour-Doppler show presence of the vessel in the center, and spectral analysis show it is arterial. These findings indicate focal nodular hyperplasia. And this is not a single example. It is a constant example in these cases. Another patient, again, same findings. Middle-aged female, slightly hypoechoic mass in the liver, shown a vascular structure in the middle at Colour-Doppler. Again, within it, there is hepatic there is a arterial flow. And again, sorry. Oh my. Sorry. Okay. Findings indicated focal nodular hyperplasia. She wanted to make a CT, and this again, findings confirm focal nodular hyperplasia. But it was so easy and simple to make it with ultrasound. And then a stent in the left renal artery, and Colour-Doppler shows easily, that is qualitative evaluation, demonstration of patency. But from this information, we can go further, and is it normal or stenotic? So we can go further, and from a qualitative demonstration of patency, we can go to identify presence of stenosis and measure its degree with measurement of quantitative evaluation, systolic peak velocity, mean velocity, and blood flow volume. At this moment, we have to remind one thing. Remind the equation. The equation is an equation which has two unknowns, because delta F is measured by the machine, but we do not know the velocity and the angle between the flow and the direction of the beam, ultrasound beam. Then we can and we have to provide this kind of information through Doppler angle adjustment to the machine in order to make the equation from two unknown into one unknown, and then can be measurable. If we provide this kind of information, the angle between the direction of flow and the direction of the ultrasound beam is that, then the machine can measure the velocity. So this has to be done if we want to make reasonable, true measurements of velocity. But why is it important to measure velocity? Because there is a strict relationship between vessel diameter and flow velocity. Since it is a reduction of the volume of the area of the vessel, there will be quadratic increase of velocity. So the increase of velocity is a very early sign of reduction of the diameter of the vessel. The measurement of peak velocity is the technique we use to evaluate presence and degree of stenosis, and the highest measured value has to be considered. And stenosis is diagnosed if peak velocity exceeds the normal values. The higher the peak, the higher the stenosis. We have to use a Doppler angle around 60 degrees, and we have to know which are the reference velocities within each vessel. For instance, stenosis of renal artery is diagnosed if peak velocity is higher than 180 centimeters per second, or 3.5 times higher than the velocity in the aorta. This is our patient who showed at the beginning with the stenosis at the middle third of the right renal artery. Measurement of mean velocity can be done also using a Doppler angle less than 60, imaging a long rectilinear segment of the desired vessel, and using a sample volume encompassing the word vessel diameter. And from the measurement of the mean velocity, we can even measure the blood flow volume, multiplying the mean velocity per the area of the vessel. However, which is the reproducibility of these measurements? It is not good, because it has been shown that there is significant intra and inter-operators variability, significant variability among different types of ultrasound equipment, and common training programs only can reduce the operators' variability. And these quantitative data, which for instance are very useful to follow up patients with liver cirrhosis, can be used to follow up these patients only if using the same technique and the same machine, and possibly using the same operator. Furthermore, semi-quantitative evaluation. It has been shown that spectral analysis, each vessel has a specific flow pattern in terms of spectral width and systo-diastolic relationship. Then, at spectral analysis, each vessel has a specific flow patterns, and changes indicate pathology. But how and why Doppler signals are different in different vessels? First, let us remind, in a cylindrical vessel, blood flow has a laminar profile due to friction of red blood cells on the vessel wall and among itself. If we have a large vessel, friction is mostly at the edges and not in the center. Then most red blood cells run at the same velocity, and there is a blunt profile. You can see on the lower image that the colors change with a blunt, more or less blunt profile. And the same, it can be seen by the spectral analysis. The resulting spectrum is narrow. On the contrary, the small vessels have a full flow profile which is parabolic. You see there is a parabolic appearance within the vessel at Colour-Doppler. And the resulting spectrum analysis is wide spectrum. So each vessel has its own signature according to the type of diameter it has. Furthermore, physiological changes at the flow profile can be seen at the bends and bifurcations with retrograde vortices in bifurcations and higher velocities along the outer diameter of the bended vessels. Furthermore, there is a systo-diastolic relationship. Do you want something? Okay. There is a different systo-diastolic relationship among different vessels because there are vessels with low resistance, usually those which go to parenchyma, to parenchymal districts, and high resistance, those which go towards muscular districts, which will show low or absent telediastolic flow. And there will be physiological changes. This on the left is the superior mesenteric artery at fasting, and 15 minutes after meal is seen on the right-hand side. You see how different is the systo-diastolic relationship. This you can be seen in the aorta. The distal part has high resistance, the lower, the resistance is the proximal one before it goes to the liver and the kidneys. The superior mesenteric artery, high resistance in fasting, low resistance after meals. Uterine, normal, high resistance in pregnancy, low resistance, and so on. How can we measure this relationship? Using the pulsatility index, systolic minus diastolic divided mean velocity, or the resistive index, systolic minus diastolic divided by the systolic. And since this is a relationship, there is no need for angle correction. And now, pathologic flow signals. Flow is disturbed from parietal plaques. There will be not anymore a parabolic regular flow because plaques disturb. Then you see here on the bottom right a vortex which is created by an ulcerated plaque. And if we put the sample volume in the middle of the vessel, it is a very narrow spectrum. If we put the sample volume close to the ulcerated plaque, you see it is starting widening the spectrum. Second, increased velocity and marked volumes when there is stenotic flow. The increased velocity because the physiology tries to maintain blood flow quantity across the stenoses, and there will be the vortices with spectral broadening after the stenosis itself. And then, when there is a very tight vessel, there will be complete loss of laminar flow. Just when you look at the flow of the river Nile in the rapids of the Nile, there are many small vortices, even with retrograde flow, and which are running very, very fast. And you will have complete loss from normal to stenosis to turbulent flow, complete loss of laminarity, and also some retrograde signals, which are written below the baseline. Changes of cysto-diastolic relationship from lesions distal to the sample volume. And we can have increased resistances. For instance, which they are shown as lowering of the diastolic component of the waveform. And the higher the resistive index, the lower the diastolic component of the waveform. This can be seen, for instance, in a patient with normal vessel. You see, this is the normal renal waveform. But if the patient has nephroangiosclerosis, which reduces the flow, the vessel diameter throughout the kidney, you will see that there is much less diastolic component. And this can be seen, for instance, also in reduced vascular bed for vasoconstriction, or before a severe stenosis or before a severe plaque. Such changes can be seen also when you observe systole and diastolic flow in normal nephrangiousclerosis at Colour-Doppler, but can be measured only through calculation of the resistive index at spectral analysis. Reduced resistances, which means increased diastolic components of waveform, which increased flow visibility at Colour-Doppler. You see, this is a normal artery at the left forearm of the same patient here, who has at the right forearm an AV fistula for hemodialysis. You see that since there is an AV fistula, there is marked reduction of the resistances, increased velocity of flow, and decreased resistances with markedly increased end-diastolic components. These changes can sometimes also seen in arteries which are feeding a tumor which is hypervascular. This can be seen also in patients with physiological vasodilatation or from drugs or inflammation on hyperfunctioning glands. This is a normal thyroid, and this is the thyroid inferno in hyperthyroidism from Graves' disease. Then we have the to-and-fro blood flow, which is flow towards a closed chamber. And it can be seen at the neck of pseudoaneurysm, in transplanted kidneys with venous thrombosis or severe rejection, or flow towards necrotic tissues. What does it mean? In systole, when pressure within the vessel is higher than that within the, let me say here, the pseudoaneurysm, flow enters into the pseudoaneurysm at the neck. But then in diastole, when flow within the vessel has lower pressure, there is a higher pressure within the pseudoaneurysm, then flow gets out from the same neck from the pseudoaneurysm. So it is flow which is go to and fro, and does not have any possibility to provide blood, oxygen, and nutrients to the tissue. In a clinical case, 57-year-old woman who underwent renal transplantation, she received 2 kidneys, here and here, in the right iliac fossa from a marginal donor, who was an old patient. And post-operative day 3, she developed pain, proteinuria, and slight increase in serum creatinine. And I was called to make an ultrasound examination, and these are the 2 kidneys, the upper and the lower one. And these are flows at the renal hilum of the 2 kidneys, the upper and the lower one. What do you see? There is flow which is going in, out, in, out, in, out of the lower kidney. So, flow in the lower kidney enters into the kidney in systole, but is retrograde in diastole. Since there are 2 different situations in which a similar waveform can be seen, as we said before, severe rejection or renal vein thrombosis, we have to decide which of the 2. But since the rejection is a systemic situation, while in this case, abnormalous flow is seen only on the caudal kidney, this pathology involving only one of the grafts, and then the diagnosis is thrombosis of the renal vein. The patient underwent surgery, and luckily, she could go on only with only one of the 2 kidneys, and did not need any transplantation anymore. And then changes of cysto-diastolic relationship from lesions which are proximal to the sample volume. The first case we showed, disorders of rhythm. Then you see that here there is a arrhythmia. The first part has a lower systolic resistive index than the last part, because it's also due to the eighth of time. In valvular diseases, this patient has a retrograde flow in diastole, but this is at the level of the aorta. The patient has reflux in diastole due to aortic insufficiency. Or this patient has a very tight stenosis of the left superficial femoral artery, and this is the increased velocity top left. But what did I do? Oh, okay. I did not do anything. But on the bottom, if we go to the popliteal region, we see that there is very low systolic velocity and very late peak. This means it's a post-stenotic parvus-tardus flow. And the same can be seen here. Normal side in renovascular hypertension, the flow as normal on the left, I think, if I remember correctly, while it is low velocity and slow raise of the peak on the stenotic side. This is called the tardus parvus flow, which is due to pressure drop across the stenosis and also compliance, linked to compliance of the peripheral vascular bed. And we have a last case. Last case. Young woman, 31st week of pregnancy, found hypertensive, sent to ultrasound Doppler for suspected renovascular hypertension, and this is the finding you see at the right kidney. What do you see? Late Tursus tardus flow. This seems to be a stenosis of the right artery. But look at here. This is what you see at the left renal artery. Again, pulsus tardus parvus. Pathological flow at both kidneys. Post-stenotic flow on both sides. Yes, it is possible to think about a renal stenosis, but let's consider also something else. What is which unites blood flow in both kidneys? The aorta. As a matter of fact, she had an aortic coarctation. Thank you very much for your attention.